Hello, everyone. Good morning. Welcome to University of Toronto Continuing Professional Development Hematopathology Community of Interest meeting, the June 2025. Today, we have a pleasure of introducing our speaker, Dr. Clinton Campbell. He's the Division Head of Hematopathology at Hamilton Health Sciences and Assistant Professor in the Department of Pathology and Molecular Medicine at McMaster University. He has received numerous peer-reviewed grants and has authored multiple research publications in the field of digital hematopathology and AI, applied pathology. Dr. Campbell research focused on the technical development of digital pathology, hematopathology tools, including the application of AI to whole slide imaging and multimodal dataset in hematopathology. Welcome, Dr. Campbell. The title of Dr. Campbell's talk is Hematopathology, the Digital Hematopathology Current State Challenges and Future Opportunities. The floor is yours.
Thank you, Sadaf, for the great introduction. I really appreciate that. So I'm going to share my screen now. Okay, so thank you very much again for the introduction, Sadaf. And as you mentioned, the title of my presentation is Digital Hematopathology, Current State Challenges and Future Opportunities. My disclosure is that I'm a member of the Scientific Advisory Board at Huron Digital Pathology. And the objectives for my presentation today are to review the current state of whole slide imaging in hematopathology particularly, including the unique challenges associated with this, summarize current AI approaches briefly in hematopathology workflows, and explore future opportunities for pathologist-driven innovation in whole slide image, in AI and whole slide image development. Sorry, I'm trying to minimize the screen. So at a first principles level, I think it's important to review how we work as a pathologist to make a diagnosis, as it's really important for an understanding of everything we're doing in digital pathology and AI. Basically, we start off with a clinical state X of a patient, and we take some measurement. This could be like a CBC, it could be a tissue biopsy, it could be any test, and we extract information. We end up at some clinical state Y, and we call this, so to speak, a diagnosis. So basically, we know something about something, and we kind of have this information summary about the clinical state, the relative clinical state of a patient. And the diagnosis is really a shared responsibility between the clinical team and pathologists. To look at this in another way, again, we have a clinical state, and we lower the entropy or uncertainty about this clinical state by extracting information. Still, the center point of all of pathology, regardless of all the other digital information we have, is morphology, the microscopic features of tissue. And extracting information from this tissue is what I would call morphological semantics, where we take information we see in this tissue and we transfer it into a written pathology report. And it follows from this that a fundamental paradigm of pathology is that microscopic features of tissue are central to a diagnosis. So tissue features are biomarkers of disease. And still morphology, I think, is kind of the central point of all of a pathologist's job and workflow. It's also really important to emphasize that pathology is multimodal. So when we're talking about looking at glass slides or whole slide images, this is only one part of a pathologist's workflow, as my colleagues would well know. So we have morphology, we have clinical data, and we have other ancillary data. This is particularly relevant in hematopathology, I think, as compared to other pathology specialties. And when we put all this information together, we make what I would call a patient representation, kind of an overall interpretation based on all of this information of the current diagnostic state of a patient. So whole slide imaging, relevant directly to this talk, is only one part of this multimodal workflow, this multimodal digital workflow. And just to emphasize what I think is the multimodal data nature in hematopathology, this is kind of an average breakdown of what I would estimate is my workflow on a particular case. So really, you can see that I'm looking at flow cytometry, clinical data, molecular data, imaging, and other data. And microscopy is only, I think, a small part of this, probably about 25% on average. So most of this information actually is already digital. So all of this stuff here is digital. This is part of digital pathology. Whole slide imaging, which I think is arguably the most important part, is a smaller part, but yet because it's so important, it's an ongoing challenge and very important to get this right. So how is digital pathology currently defined? If you actually look in terms of the Digital Pathology Association for defining digital pathology, It's now defined as a combination of all these different techniques. So computational pathology, data science, these are kind of both related. AI is somewhere in that kind of area. Machine learning, also overlapping with AI, and whole slide imaging. And we use all of these techniques together to advance pathology practice. So this is kind of really the most modern and up-to-date thinking on what digital pathology actually is. What about the value propositions for digital pathology? And I've put here what I think are some of the most commonly cited value propositions for digital pathology. So it's often cited that there's a cost savings, increased workflow efficiency, whatever that means. I think that's very nuanced. The ability to do remote and off-site diagnostics and virtual peer review, and the ability to use computational tools. I think in terms of whether the digital pathology is actually a cost savings or results in increased workflow efficiency is still a matter of debate. If you look at the literature, some studies do show a long-term cost savings. Other studies show that have done digital pathology for several years show there actually is no general cost savings. In terms of workflow efficiency, again, I think it's really important how we define what workflow efficiency means. If it means that every pathologist works faster, it's actually not universally demonstrated in the literature that this is true, although some studies do show this. So I think we still have to learn more about this, particularly within the context of our own healthcare system in Canada. I think we would all agree that remote diagnostics is a clear value proposition. I'm not advocating for always working off-site, but I think the ability to do this, particularly to provide consultation for non-subspecialized colleagues, is very important. And I think for sure, computational pathology is a value proposition because the whole slide images that we gain are a substrate for applying AI algorithms. So what is whole slide imaging, which I think is a cornerstone of digital pathology? In the simplest sense, we take a glass slide, we take an image of this glass slide in a digital scanner, and we generate a virtual slide, a high-resolution whole slide image. And I'll put this out there as kind of a question, and maybe people can give me feedback on this later on. But is the option to view an entire whole slide image in digital pathology a requirement? I don't know the right answer for this, but I think that I will say if we do want to do digital hematopathology in a diagnostically meaningful and scalable way, we may not be able to achieve this in the near future. So what about adoption of whole slide imaging? How many centers have actually adopted digital pathology or whole slide imaging? This is actually quite a challenging question to answer. And I looked around for quite some time on this. The best answer I could find came out of CAP USA, where it estimated last year, toward the end of that last year, that the digital pathology adoption rate in the US is around 10%. I don't know about other people, but to me, this is surprisingly low. I would have expected to have a higher adoption rate after approximately 10 years of digital pathology being mainstream. So I think in summary, to me, this appears somewhat low. I don't know what the answer is in Canada, but I imagine it's much lower than this. Some of the ongoing challenges to digital pathology that have yet to be mitigated, I think, here are the upfront capital cost and the ongoing storage costs of these whole slide images. Interestingly, also, adoption is almost entirely in surge path. So hematopathology whole slide imaging in terms of cytopathology remains largely absent from routine large-scale adoption. So the question is why? I think, and this is what I want to focus on and try to get feedback from the community on. What are the hematopathology specific factors that have delayed the adoption of whole slide imaging and hematopathology versus other pathology subspecialties? For those who aren't in hematopathology, particularly bone marrow pathology, this is an overview of the different main high-level components of a hematopathology workflow. We have cytology, which is looking at cells and aspirate smears and peripheral blood films. We have histopathology, and we have ancillary studies like molecular reports and flow cytometry. For the purposes of this talk, I'm defining digital hematopathology as cytopathology. And I'm doing this because this is where the unique challenges particularly lie. Taking a whole slide image of a trephine core biopsy or a lymphoma needle core or whatever specimen you have is no different than doing any other histopathology whole slide imaging. So that can be covered in those type of workflows, but the challenges remain around cytopathology. So I think in summary, and I'm going to go over at a high level why I think this is, whole slide imaging in hematopathology or cytology, because heme path smears are really a subset of cytopathology, is unique and different. There are unique specimen characteristics. There are unique parameters and characteristics around data acquisition and storage. And there's a unique workflow to these specimens. And all of these things have factored into the delayed implementation. So at a basic level, what are the determinants of whole slide image quality? And this actually doesn't just apply to hematopathology, but to any digital whole slide images. But understanding this, I think, helps us to better understand the inherent challenges in hematopathology whole slide imaging. So if you look inside most digital scanners, you'll find two basic components, a microscope and a digital camera. Many of them actually have microscope objectives within the scanner. And you undergo a digital to analog conversion from your optical image to your digital image. You're capturing this digital image. And there's different features or parameters in both of these areas, microscopy, optical microscopy, and digital microscopy, that I think are important here. So in optics, we have things like the optical path and the resolution, your focus and your magnification. In digital imaging, some of the more important, I think, characteristics to this discussion are digital resolution, data compression, and color fidelity. So I'm going to touch on some of these characteristics. Just to emphasize the difference between an H&E tissue section and a bone marrow aspirate smear, you can appreciate right away that this is a much more complex and color complex and physically complex specimen. There's variable thickness, there's a lot of color complexity, and there's also a very limited usable area. There's only small portions of this slide that are actually suitable for interpretation by a hematopathologist. So at a very simple level, I've made this disclaimer, this is a very simplified cartoon example of this, but I think it attempts to get across the salient points. If you look at a slide that's an H&E section versus a bone marrow smear, for example, the H&E section is going to be much more uniform and thin. The aspirate smear is going to be generally on average thicker, and there's a lot of variable thickness. And right away, this leads to a couple of problems with whole slide imaging, and I think anyone who's tried this will have experienced this. For example, at the microscopic level, when you put a cover slip on these slides, you're going to get more bending and more air relative to the tissue sample on an aspirate smear versus an H&E or a tissue section. So when you have your light source, again, this is a very simplified example, and this is your optical path, you're going to get more refraction because the refractive index of air is different from that of glass and tissue, which are relatively similar. And basically, you want to match refractive indices of the slide components as much as possible to minimize optical distortion. So you're going to get out of focus areas. So then the question becomes, how do you choose the appropriate focal plane? What if you have to capture a full whole slide image, which focal plane do you rely on to make your diagnostic interpretation? And I think that's a very simple, pragmatic, ongoing challenge. And some people might say, well, let's put immersion oil on the slide. And this is true. Immersion oil has a very uniform refractive index, and it basically takes care of this problem. The caveat with that is that I think integrating oil immersion into a whole slide image workflow is unlikely to be practical. And the scanners and vendors that I've seen so far don't do this at a whole slide image level. There are parts of slides, like things like Celavision, that we use oil, but I don't think, based upon what I've seen so far, this is likely to be practically feasible to have the entire slide covered in oil or some other optical medium that's liquid-based. The other thing I want to talk about is your actual focal plane. So in general, in terms of optics, and this is just on an average basis, you're going to use higher magnifications in cytopathology and smears. And so, some people might say, I want to image the entire whole slide image at 100x. I don't know if that's actually generally needed. I think maybe 100x would be very rare, but I think 40 to 60x on average for whole slide images of aspirate smears are going to be needed for most people. Generally, for H&E tissue sections, you're doing maximum 40x. There's lower magnification. Lower magnification really means less data, but it also has to do with something called your depth of field. So again, this is a very simplified example, but if you have a higher magnification, your depth of field becomes more narrow. And this is really the range in which your vertical image remains sharp. So again, the challenge becomes, if you're imaging like a whole slide image of an aspirate at a very high magnification, how do you actually choose the appropriate focal plane? And how do you ensure you're not missing something up here or down here? We can mitigate this to some extent with something called Z stacking, although there's always a trade-off when it comes to data. And Z-stacking really, really increases the size of these whole slide images to the point where they're almost impracticable to work with. But this is one possible solution. And anyone who's done imaging in hematopathology knows there's a 3D component to these slides. So in summary, H&E tissue sections are relatively thin, usually 4 to 5 microns or less. They have a relatively uniform thickness. We're generally using lower magnifications. There's a much higher signal to noise ratio. Basically, all of your tissue is signal. There's not really any noise. You have a more consistent optical path, less refraction, and generally a higher depth of field. With a Giemsa smear, like a bone marrow aspirate, you have a relatively thick specimen on average. You have variable thickness. You have higher magnifications. You have a lower signal to noise. There's very little signal relative to noise in an aspirate smear or a blood film. There's a less consistent optical path with more refraction and generally a lower depth of field. So all of these optical parameters factor into the challenges of whole slide imaging from an optical point of view. And the usable area is also smaller. Now I want to talk a little bit about the digital component. And I think some important concepts to this in a very simple sense are resolution, magnification, and data. Magnification in the simplest context would be size of an image compared to the real object. Resolution is really how much fine detail can be distinguished. And these get a little bit confounded because often objectives that increase magnification also increase the optical resolution. So it can be hard to parse these apart. If you think of optical resolution, it's really the minimum distance that 2 points can be distinguished, and it's defined by something called the Rayleigh resolution limit, depending on your wavelength, which is fixed in your numerical aperture. So higher numerical apertures generally give a better or higher resolution, or a smaller resolution limit. Digital resolution is a little bit different. This is actually thought of or defined in terms of pixels per unit area. Another way to think of digital resolution is pixels per size. So an average digital resolution at a 20x for a whole slide image would be 0.5 microns per pixel. And this is determined by something called Nyquist sampling, which really just says that your digital resolution should be about 1/2 your optical resolution. And there's a nice review that kind of goes over this and describes why this is. This is a really important implication, though, in terms of hematopathology whole slide images, again, because you're generally using higher magnifications. So when you double your digital resolution, you're basically going to quadruple the number of pixels. So you can't just take a whole slide image and blow it up and make it bigger, right? Because you'll just see a more grainy image. You actually have to increase the digital resolution, or there's no point in actually increasing the magnification. So if you're doubling the magnification, you're basically going to quadruple the number of pixels, and you're going to have about 4 times the amount of storage. This is not generally covered well in the literature on digital pathology and your storage needs. So for example, this is a nonlinear relationship. So as you scale up your magnification, your pixel size is going to go up by an exponential factor. And this has really, really important implications on the storage requirements and the management of this data when you're using this in an actual pathology workflow. To give a simple overview of the relationship between resolution and magnification of data, for example, if you have a 2.5 by 5 area that's scanned on a glass slide, not even excluding the label, let's say you scan it at 40 times magnification at 0.25 microns per pixel, your total pixel count is going to be 100,000 by 200,000. This is about 20 gigapixels of uncompressed data. So this is like big data. This doesn't even take into account compression. And just to give everybody an overview, if you're interested in this kind of thing, we do standard 24-bit RGB color sampling, usually when we do these. So this is 2 to the 8 or 256 colors per channel. You have 2 to the 56 to the power of 3 total colors. In terms of information theory, there's 8 bits in 1 byte. So you're looking at 24 bits per pixel times 3 bytes per pixel. So if you actually look at the size of this 20 gigapixel uncompressed image, you're looking at a 60 gigabyte uncompressed file size. So take that into consideration that a digital image from like an iPhone might be around, I think, 30 to 50 megabytes, right? So this is before compression, how big a whole slide image could be in hematopathology. And this gets into another really important, I think, an interesting area, and that's data compression in whole slide images. And you might be surprised to know, but actually at the same magnification and image size, uncompressed whole slide image sizes, regardless of what it is, are approximately equivalent. The difference is in the efficiency of data compression. So if you use something like JPEG or JPEG 2000, you get about a 10-to-1 compression. So your 10 gigabyte image becomes about 1 gigabyte, and this is basically universally applied. One really important nuance of this is that the areas that are more color complex have less efficient compression than the areas that are less color complex. But if you look at a hematopathology smear, like a Giemsa smear, the entire slide is color complex. So the entire slide is going to have less efficient data compression. This is much more of a problem than it is with a whole slide image. And on top of that, many digital scanners will have a pre-scan algorithm where they may select the appropriate area for scanning and further reduce the size of that whole slide image. So this is something, again, that is going to have to be addressed by the field to make these images useful in an everyday workflow. Here's a very simple model from an example in the literature of the growth of whole slide image data in a year. And again, this assumes linear growth, which is probably actually not accurate in terms of an actual whole slide imaging workflow. So let's say, for example, you scan 1,000 whole slide images per day at 1 gigabyte per slide. That's about a terabyte per day. Times 300 days per year is 300 terabytes. If you add redundancy, you're at least doubling the size of that data. So you're up to a petabyte of data per year. If you add hematopathology smears, at best case scenario, and I mean best case, they're 4 to 6 gigabytes per whole slide image. So we do 1,500 bone marrows per year at our center. Let's say you image 10 slides per bone marrow per patient at 5 gigabytes, best case scenario. You're adding about another petabyte worth of data. So you're doubling the size of your storage requirements. And this kind of thing has to be accounted for if we actually want to use these whole slide images from hematopathology in everyday workflows. And I haven't really seen any models in the literature so far that address this. There's also an impact of larger images and more color complex images on scanning time. And of course, scanning time has to be efficient. And again, in the chart here, this is just a simplified example. Your local centers may have faster or slower scanning times, but on average, if you look in the literature, it's around 2 to 4 minutes at 20x for a histopathology slide. 40x is a little bit more. My experience, and based upon discussion with colleagues with hematopathology images at 40x with Z stacking, you're looking to 10 to 20 minutes or longer to scan a whole slide image. And this really, throws the question of practicality in your workflow into the discussion, because this is not likely going to be amenable to a high throughput workflow. So those are some of the actual physical parameters in terms of digital images and glass slides. What about the actual workflow? So anatomical pathology, again, is a bit different because we have batched workflows, right? If we have 3 patients, generally, you want to process, embed, stain, cut all these specimens in a batched way, and you want to scan them in a batch way. You want to maximize the space inside the tray in your scanner because you don't want to be running it with empty trays. So there's a lot of logistics and informatics planning in the lab around digital AP workflows. Hematopathology is different though, right? For aspirate smears, this is basically on demand. So like in the center here where I work, we go from patient to pathologist in about 4 to 6 hours. You do an aspirate, you fix it in methanol, you stain it. And these are often clinically urgent. You have to look at them pretty fast. So these are unlikely, just on this basis alone, to be amenable to the same scanners or even the same workflows that we're using for histopathology. We're likely going to need different workflows and scanners, and different scanners for other reasons other than this that I just talked about. Z stacking, again, as I mentioned, is one way to possibly mitigate this, but the images become much, much larger. Basically, this means we take different focal planes. Essentially, we have kind of a 3D specimen, and it helps to deal with things like particles, which are 3-dimensional and overstaining, but the images get very, very large. So these become a problem, but this is one thing that may be in some sense used in hematopathology. The other thing I want to talk about is color complexity. Romanowski stains or Giemsa stains is an example of that, have unique color characteristics from H&E. There's a much broader range of colors and there's different staining protocols. And almost every heme lab or hematology lab has a different, formulation of their Giemsa smear. So these scanners are all going to have to adapt to this. And the Pearl stain for iron is also a different color complexity. So whatever scanner we use for hematopathology, we need to accommodate high color fidelity and probably a broader dynamic range of colors which I'm not sure all the scanners that are used for histopathology are designed to do. So just another thing to think about in this context. So in summary for this part, whole slide imaging in hematopathology, in my opinion, is different. We have very different specimen characteristics from AP. We have larger data requirements on average, and we have unique workflows. Okay. So I want to talk a little bit about AI and some of the work that my team has done over the past few years, and then go on to kind of talk about how this all might kind of fit together going forward. In terms of using AI in pathology, this has been talked about a lot in the last about 5 to 10 years. Most of the papers published on this have been in the last maybe 5 years. And again, I would break this down to maybe 3 key areas that AI has been or will be used or is being used in pathology. One is the problem of detection and classification. I think this is where it's being used the most. So things like identification of cells, patterns, regions, grading, and helping in diagnostic support. And there's some FDA-approved tools for this, including hematopathology, very few. But this is directly relevant to counting cells in bone marrow aspirate smears. Representation and search. This is kind of a different area where we actually may extract features, embed whole slide images or embed cells, and do archival search. So compare the embeddings or the representation by AI of what you see in this whole slide image to that of other whole slide images and see what your colleagues actually said about that, right? And this is kind of, I think, an area that's not being used mainstream, but will be very, very important in the future. And something that's not really as cool and not often talked about, but being used as workflow optimization. So some whole slide image scanners already have AI built into it to help, look for artifacts and optimal regions of interest, QC of the slides, whole slide image reconstruction, and triage. So this is some of the areas where it will be used. If you look at a general schema of AI classification in any pathology specialty, and regardless of what it is, really, you're going to be doing something like this. You'll have a deep model, some type of deep neural network that's extracting features. Usually this is fine-tuned through supervised learning where you're actually have pathologists labeling and going back and adjusting the weights of the network based on what they see in these images, although there is some use of things like self-supervision now in these, but that's more in the domain of large language models. And then you apply a classifier, again, which is usually trained through supervised deep learning, and you make a prediction, right? So triaging cells, grading tumor versus normal, grading tissue, counting nuclei, counting cells. And there are some examples of this actually being used in the literature and clinical practice. And some of the stuff I'm going to talk about relevant to bone marrow follows this kind of a schema. Really the kind of interesting, and I think, thinking point of all of this is it really requires general acceptance by all pathologists, right? If you're going to buy or use or purchase or integrate an AI model into your practice that's proprietary, you're going to have to accept the result. The community is going to have to accept it. And this is really, I think, an ongoing and not completely addressed problem in AI classifiers in pathology. Representation and search is another area that I think hasn't been used so much, but could be used in a meaningful way, where again, you extract features from, let's say, an aspirate smear or a histopathology image in a supervised way, usually, and you may make new representations of information. So you may embed a whole slide or a cell and look at it through dimensionality reduction. You may represent, cells in an aspirate as a histogram, which is something we did, and it's a more efficient way to do this. You may do a database search where you compare the representation of your image or cell or cells to a database of other pathologists who have already labeled these images, and you say, what did the experts say? So you're essentially comparing what you see or what the model's showing to what other experts have seen. So this is kind of an unsupervised approach and something that my team and collaborators have worked on regarding this. So in terms of specific applications of AI in hematopathology, I think if we're going to extract features, we can do several different things that I'll talk about briefly. We can classify and pre-classify. I think this is an obvious application of AI in hematopathology, to classify and pre-classify cells. And there's many publications on how to do this now. To compactly represent information. Again, I think really, really relevant because compressing a whole slide image doesn't necessarily mean you have to just compress it and have the whole image. It might mean you actually may only look at certain relevant parts of the image, right? Or a certain representation of it. And doing search, where again, I think I just talked about that, but looking at the representation of a cell or a whole slide and looking for similar images. And this just shows a schematic of, my team was one of the first groups to propose a solution for an end-to-end model for counting cells in bone marrow aspirates, although since that time there have been dozens of different publications, very valid publications on different ways to do this. So there's not one way to do this, but essentially we used multiple different deep networks to find the regions of interest on a whole slide image. We sorted through those tiles and we counted cells using something called a YOLO model, which is an object detector and classifier, a deep learning model that comes from self-driving cars, actually, to classify these cells. And we basically flipped through all these tiles and cells and generated a histogram. So it's like a super differential count consisting of tens of thousands of cells. And we represented a whole slide image as something called a histogram of cell types. And when we actually use this histogram to search across a database, we can pull up similar diagnostic interpretations. And again, this is a very simplified representation, but just one example of how this could be achieved. But I want to emphasize there's many other ways and very good ways of doing this. There's not just one solution to this problem. We also looked at using the embeddings of cells to make a compact representation. We call this a cell projection plot. So basically, if we take the feature vectors or embeddings of each cell inside the backbone of this model, we can look at this in a dimensionality reduction plot. And basically, the size of these plots are like 10 to 20 megabytes. So this is a compact representation. Again, is this a solution for actually viewing a whole slide image? Maybe, I don't really know, but when we looked at it, we got a good concordance with the actual diagnosis when pathologists just looked at this. But, I think most people can look at this and say, this looks like it represents normal hematopoiesis in the bone marrow. This looks like maturing granulopoiesis. So like a quick snapshot in a compact way using AI embeddings to represent a whole slide image in a much more efficient way. And finally, we can kind of put all these things together. I didn't talk about our large language model work that preceded this, but we used a BERT model to label whole slide images. But when we take the embeddings from a YOLO model, we use slide labels from a model called BERT, which is an early form of a large language model, and we pool these together using attention. We can actually represent all of the cells on a whole slide image as a single vector. And again, this is not really for prime time right now. This is an early view of what could be achieved in the future with the appropriate whole slide image data sets. But if you look at a plot like this, each dot actually represents the embedding of a whole slide image. And this is not a clustering algorithm. This is just a dimensionality reduction plot. And you can see some patterns begin to emerge. And when we search across a database based upon these whole slide image vectors, we can get a better than average prediction of what the diagnostic label would be. It's certainly not perfect, but it's an early proof in principle of how you might use a technology like this. So these are just some examples, and there's many others of these coming out now of how, the community, we can use these things potentially now and in the future to help our diagnostic workflows. And here's an example that we proposed of using this type of a system as a clinical decision support tool. So you might, let's say you embed a whole slide, you could search a vector database. It's an actually geometric distance from your embedding to other embeddings. And, if within a certain distance, all of these were labeled acute leukemia, it might help give you confidence that your interpretation is correct, right? Again, very simple example, but something you could use these models to do. And you can even rank the different cells that were weighted by the models and visualize them and all these kind of things. So that's just an example of a possibility. Some scanners like the tissue scope from Huron use AI to help pre-scan algorithms. This is something that, again, is a little bit less talked about, but very tangible application of AI in digital pathology. And given an example in our work, we trained a neural network to basically find the regions of interest really fast on a whole slide image at a very low magnification, and you can see the approximation of that here. So this is an example of using AI to just find your regions of interest. I think a much more practical and something that's likely to come into clinical practice much easier than some of the other solutions that I've just talked about. So what about the actual development to implementation of AI? So another thing that I kind of looked at just out of interest is approximately how many papers have been published on AI and hematopathology smears, like ever. And I did kind of a Boolean search in PubMed to look at this. And the first paper that I ever found that had anything to do with AI and hematopathology was in 2017. And I found 166 results. This was like, a month ago or something. Again, it's a little lower than I would expect. I thought it would be more, but it's not insignificant, right? There's, some of these are review articles too, so there might be around 100 papers of research. The other thing I kind of asked is how many of these are actually FDA cleared? How many of these have actually been developed and implemented as an FDA cleared product? And this is very transparent. For anybody who wants to see this, you can go to this website and you can see a list from the US government of all of the AI software as a medical device products that have been FDA cleared. And there's not very many. And it's very interesting to see this list. I found 13 of them that were hematology related. Not all of them had directly anything to do with blood films or aspirates. Some of them did. None of them actually represented new AI technologies that had previously been proposed in the literature. So I thought that was really interesting. Whatever it means, I'm not exactly sure, but I think, the need for whole slide image data sets that are robust and generally shareable to the community is an obvious implication of this development to implementation gap. So to summarize this current and future state of AI and pathology in a very high level, I think personally AI can potentially analyze smears, blood and bone marrow smears with accuracy comparable to human experts. I think that's really clear to me now, just on what I've seen in the literature. And I think there's many AI solutions to this. And I think the way we're going to move forward on this is many different individual solutions that do the same thing. And they're just going to keep getting better. Current areas of interest that I could talk about in a separate presentation in AI relative to in relation to pathology are things like whole slide image representation that I just talked about. It's a very hot topic in the field. And we also published a paper on representing whole slide bone marrow images that I didn't talk about today. Multimodal search, I think, is kind of a buzzword, but something that's going to be tangible where we search across different data modalities based on models that represent embeddings, and things like retrieval augmented generation, where we give transformer-based models like language or visual transformers a little bit of help to check accuracy by drawing on a database, right? So that's something else that's kind of going to be interesting in the future. I will say, kind of to go into the last few minutes of this, that this work, in my opinion, is unlikely to be impactful to the community without robust, high-quality hematopathology whole slide image data sets. So I think, personally, I kind of put a pause on doing some of this research because I thought, well, what are we going to do with any of this if we don't even have hematopathology images? So I think this is a more important problem right now for the field. So briefly, what is the current commercial landscape in hematopathology? There's a few major vendors that people may have been familiar with in the field. So one, of course, that's really is a digital pathology tool is CellaVision. So CellaVision is older tech. It's meant for MLTs to support manual differential counts, and it doesn't give whole slide images, and there is no commercially available bone marrow application. Whether or not this is meant for pathology sign out, I think that's an individual hematopathology preference. Some people use this for interpretation of blood smears. Some people don't. Like, I'm not exactly sure if I feel that this is meant for everyday routine sign out, but for simple cases, you can use it to a certain extent. But really, the cleared FDA application for this is for manual differential counts by MLTs. And this doesn't take a whole slide image. This takes an oil-based, low-resolution thumbnail snippet of a blood smear. There's a system called Morphogo that's been advertised. I'm not exactly sure what they offer. It's hard to find information on it. It's unclear if they offer whole slide imaging. They have limited validation of an AI preclassifier that's shown in a couple of papers. Probably the most known company that's offering a possible solution to hematopathology is called Scopio. They don't offer whole slide imaging. It's something called full field, which is my understanding. I don't fully understand, again, what it is from the literature and talking to them, but it's scanning a part of a whole slide image. And we have one multi-site validation of the imaging and AI technology that's built in. I think what's really important, though, to mention, again, this is kind of just my opinion, but these are proprietary algorithms and they limit transparency. And understanding often relies on reviewing the patents. So I've reviewed the patents on these. I've actually looked at how they work, and that gives some sense of what they're actually doing, but it doesn't fully answer it. And I will say, and again, this is something for colleagues to think about, that if I'm going to sign out a whole slide image and I'm going to put my name on it and make an interpretation, I want to understand how that image was constructed. And I'm not saying to make open source code for all the AI, but I think understanding the basic architecture of whatever networks were used is going to be essential, at least for me. Otherwise, I wouldn't use the image for my routine practice. And that's not the case with most of these technologies. So kind of the current paradigm in whole slide image tech development is that basically you have a proprietary kind of in-house development and design of a digital scanner and an image management system and even the AI. And we ask pathologists to validate this, whatever that means, right? Look at it, look at some slides, tell us if you like it. I think we need to think of more collaborative pathologist-centered models to this, where basically we have pathologists actually involved in the design, we have open development and design, and we have continuous feedback. I think it's really, really important that pathologists be working with these companies and directing them as to what we want, right? Not companies telling us, this is what we have, tell us if you like it. That's just my take on it. And this has kind of, led to my trajectory and interest in developing something that I think might work for whole slide imaging and hematopathology with a company. So funded by an OCI grant over 2 years, we're working with Huron Digital Pathology, where we're developing in a collaborative way a hematopathology whole slide image system. This is not a validation, this is an evaluation where we have kind of an in-house server, an image management-based system, and a hardware prototype where we're working in real time back and forth with pathologists to kind of develop this and say, does this image work? Does that image work? What needs to be adjusted? Is the image management system good? And I think at the end, we may come up with something that may be more useful to the community, at least having HemePath input. It's actually a prototype based on a cytology scanner. And I think for obvious reasons, using a scanner that's developed for cytology would be the logical starting point for hematopathology. And we're going to be looking at a lot of different parameters that I just talked about. How do you address some of these challenges? I don't have all the answers for this now. I think, some of them would center around whole slide image acquisition and reconstruction using AI. Some of the algorithms and approaches that I've shown. More efficient data compression is definitely going to be needed, whatever that means. Again, as I said, different representations of slides. Using things like volumetric imaging or Z-stacking to a certain extent, and something like an extended focus image, where we may actually take Z-stacking at multiple focal planes and reconstruct a single in-focus whole slide image. And some companies are doing something like this. And again, this gets back to the question, are people comfortable with viewing something for diagnosis that is not the entire whole slide image? I don't know, but I think we're actually going to have to do this if we want to use HemePath whole slide imaging in a meaningful way. So what would be a possible scenario for this? For example, let's say we have 3 different vendors, 3 different colleagues at different hospitals could work with these vendors and, evaluate or develop different solutions. And I think we don't just need one AI solution either. In fact, I don't even think that's the best idea. And likely it's not a paradigm we see in other fields. We're likely going to have multiple local-based AI solutions that are developed and validated locally, right, suitable to the individual site's needs. And they may be API-based, where we actually just plug them into different vendors. And I think we need some transparency in code. What I will say, and I don't have time to talk about, that's a really, really important consideration. If you're going to be using servers and GPUs to do, like in a data center, to do neural network training, you're going to have to adjust your power supplies and needs accordingly. Like if you look at the requirements in terms of driving these GPUs for cooling and for electricity of the big data centers that are out there, it's astronomical. And this is also a consideration even for small scale experiments. I know from practical firsthand experience is important to think about. And that's something that, again, I think is virtually absent from the literature or any of these experiments that are put out there. And I think competition is good for innovation. So in summary, like what is a case for digital hematopathology whole slide imaging? And I think it's really important to stop and think about it at first principles as to why we're actually doing this. So if we're going to do digital hematopathology, like whatever solution we have has to be fast. We need a fast acquisition time in our workflow. And I think most people will know that you can interpret a glass slide in like seconds to minutes. And so if your digital system doesn't do it just as fast, I personally don't think it's going to be useful, right? So we have to mitigate this issue. We have to have non-inferior imaging. The image has to be at least as good. And this comes up with the additional caveat, we have to have efficient data compression and storage. And there has to be a value add, right? I think remote work and cost savings, if those are true, are a value add. And I think using AI is an obvious value add that definitely will be implemented and used when we start getting these images. But it's an unsolved problem, which I think is exciting. So in summary, hematopathology whole slide imaging is uniquely challenging. Understanding even the basic physics is crucial to understanding the limitations. And whole slide imaging and hematopathology needs pathologist-driven innovation to reach full potential. So that's everything I had for today. Thanks, and I'm happy to stay for a few minutes and take any questions or discussion.
Thank you so much, Clinton, for giving such an amazing talk. Indeed, digital hematopathology and especially the bone marrow pathology presents a unique challenge. And because of the complexity of the slide, the Z stacking that is required, the AI integration, I think it is more and more crucial. And for us as pathologists, do we trust the technology? That is really important. And the most important point that you raised, and are there any researches that are going on? And if such, the researches are not that much, but it actually requires the research and development, the collaboration between the pathologists, the hematopathologists in particular, with the AI developers are the essential, the key for this to succeed. We have a few questions in the chat box, and so the first question is digital. How can human learning bias be excluded from AI application?
I think it can. I think that if you're going to do supervised learning, like bias in interpretation is part of our job, right? Like we're all biased in our interpretation. I think the key for me is averaging out biases and checking them. So if you have many pathologists labeling slides, if you're going to do this in a supervised way, the more images and the more pathologists involved, it helps to average out the bias or have sampled bias from differences. But you can't eliminate bias in AI. That's just not possible. Even the self-supervised models that you have, the large language models, they have some bias inherent because they're using data sets that are developed by humans, right? So I just don't think that that's something we're going to do, but I think we can limit it.
Thank you. Furthermore, there are no more questions. Rosemarie, do you have any question, comment?
Sorry, I see someone just posted a question, or I think it's more a comment.
There is another
Just
one. Yeah, I like Scorpio. My counts are very similar to theirs. I really do not know how they do it, but it works.
Yeah, yeah, that's the same. Yeah, I've seen them and I've talked to them a lot and I've looked at their technology and it works, but I don't know how it works, so I'm not going to use it.
Yeah, because I did recently, I think Clinton, you as well, we attended the online webinar from them, but they did not explain how it works, but they
Right.
are not even FDA approved at the moment. So they are in the
Correct.
final
Right.
phases. As for the bone, for the peripheral blood smear, they have the approval, but cell vision is pretty um, uh, pretty robust in that sense. And I think
Yeah.
most of the laboratories in Ontario and all across Canada, we have that being implemented. The other comment that I have in the question, what is the state of the art peripheral blood smear interpretation? Thanks.
I'm not sure I understand the question, sorry.
So the question is, what is the state of the art in peripheral blood smear interpretation?
Mm,
maybe Ivan, do you want to unmute and clarify if you mean in terms of the technologies that are out there, or?
I'm just wondering if there are any groups doing research regarding AI interpretation of peripheral smears, any high throughput results that you may have? Anybody doing any research? Because we have Cell Sense, right? And
yeah,
I imagine that there may be some companies trying to sell some software or any groups researching in peripheral smears.
there's lots of them. There's probably 100 papers in that topic of AI and digital smears. The issue, I mean, and again, it's kind of like I said before, uh, there's many different solutions. It's now almost like old technology to use AI to classify blood cells. That's so well established. The issue is that we have a lack of widely available data to test these on and implement them on to make them robust. And the other problem is many of them are developed on local data sets. Same with my group, right? The classifier we developed are from Hamilton bone marrow smears. So if we tested them on UHN smears, it might not work very well. And that's a really, really important limitation. So we have to address those issues. But there's many papers. If you just do a search on PubMed and AI and cytology, there's like 100 of them.
Thank you so much.
Yeah, welcome.
Great,
Do you
thank
think-
you so much.
Sorry, do you think things like color calibration would be sufficient, or is the variability in the gem sustain too much for something like that to help mitigate a little bit of the issions?
That
I
may
don't
be
remember the name,
possible,
but there's like some
like using an algorithm or something to help standardize the colors. Like that's those are all interesting possibilities. I think we need to explore that. I will say that my colleague Hamid Tizush, who was who worked with me on a lot of this work, that his lab published an interesting paper where they were able to identify the hospital from which a full slide image came with AI by actually just, they don't even nearly know why. There's something in the images that showed that. So these networks are certainly learning things and know things that we don't know about yet. And there's a lot of things like that that have to be addressed, which is why I think, honestly, maybe making local solutions that are just validated, developed in-house for your system and your stains will be important. But then what happens when you get a consult, right? How do you image that?
That's
And so
that's the
I don't
thing.
know. Yeah,
Because that could be one relevant use, like because we know there's a shortage in heme paths, and then everything is becoming more complex. So being able
sure.
to get easy consult from someone, especially if you're in a smaller center, you don't have like 5 colleagues available like easily. So it's great if whole site images can help you just have access to a network without having to physically transport slides. But then if things are not compatible, and how do you kind of
Yeah,
takes
I
away
think
some
it's
of the promise of
it's a really good question. Yeah.
Great. Again, thank you so much, Clinton, for giving us a great overview, and it was very thorough, and you provided us most up-to-date information. So everyone, please hang in there, because we do have interesting cases. And I would like to thank Dr. Campbell again one more time. This event is an accredited group learning activity, so all of you will be getting Section 1 claim up to maximum of 2 hours. And so the survey is in the chat box as well, and it will be emailed to you as well. Great, thank you. Rosemarie, you can take it.
Great. So I will invite our first speaker who brought a case of interest. Muna, if you want to check if you can share your screen. So Muna Al-Jabri is one of our hematopathology fellow who's been working with us at UHN for the past year, and she had a case of interest that she worked on with Dr. Ali Sagdari. And so without further ado, Muna, the floor is yours. Good.
So, good afternoon, all. I am Mona Jabri, fellow at Toronto General Hospital, and today I'll present one of our interesting cases that we had recently. So, our case is a 49-year-old male who has a history of multiple myeloma and was diagnosed in 2019. He received treatment actually with multiple medications, and then he received allogeneic stem cell transplant on 2021. Last July, he started to develop cytopenia, so with a hemoglobin around of 11, platelet 43. So the clinical concern was, is it a recurrence of his myeloma, or it's a peripheral, or it's a post-transplant lymphoproliferative disorder? So then he underwent a bone marrow biopsy. And this is what we received. So His bone marrow biopsy actually shows sheets of these atypical cells and these cells were distributed interstitially at paratrabecular spaces. These cells are small with eccentric nucleus and occasional cells with central nucleus with occasional perinuclear hoof, and they form around 50 to 60% of the bone marrow cellularity. There are no lymphoid aggregates seen in the biopsy. And then by immunostains, these cells shows diffuse positivity for CD20. CD138 was negative except for a few subset of cells that are positive for this stain. CD79A was diffusely positive. Memon was positive, but with variable intensity from strong expression to intermediate and some weak expression as well. BAX5 was negative except in few rare cells that showed very weak positivity. BCL2 was diffusely positive. CD10 as well was diffusely positive in these cells, but BCL6 was totally negative. IgKABA shows diffuse cytoplasmic expression in these cells. Lambda was negative, and these cells as well show diffuse IgG expression, but negative for IgA and IgM. Other negative stains are like these cells are negative for CD19, for 56, CD117, cyclin D1, and negative for EPER-ish as well. So at these points, we had like 3 differential diagnoses. Is it a recurrence of these plasma cell neoplasm? So the cell morphology is plasmacytoid. They have a MOM1 expression, but again, CD138 is negative, and they have strong 20 and 10 expression. And the second differential, is it a rare lymphoplasmacytic lymphoma with CD10 expression, and which is unusual for this lymphoma to have negative BAX5. And the last is it a follicular lymphoma because of the 20 and 10 expression, but again, morphologically, we don't have a lymphoid follicles. BAX5 is negative, BCL6 is totally negative as well. So we went back to gain more clinical information, and his CT actually showed multiple suspicious lytic lesions in the T10 and T12 vertebral bodies, and some other tiny lytic lesions in the clavirium. There was no significant lymphadenopathy and no extraosseous soft tissue masses. He has elevated serum M protein of 19 gram per liter with elevation in IgG as well, and free kappa light chain with the kappa to lambda ratio over 70. So the clinical information are in favor of plasma cell myeloma, and it's unlikely for a lymphoplasmacytic lymphoma to present with lytic lesions, and extremely unlikely for a follicular lymphoma as well to present in a bone marrow without lymphadenopathy and to present with a raised M protein or light chain. And then the flow cytometry as well showed a subset of plasma cells that had a DIM 138 and 38 expression and show kappa obstruction and no immunophenotypic evidence of T-cell lymphoma. MYD88 was negative. So the final diagnosis was plasma cell myeloma with actually negative CD138 expression, apparent 20 and 10 expression. On last May, we received the slides for his initial bone marrow biopsy, which was done on 2019, and it showed again 50 to 60% of plasmacytoid cells with exactly similar immunophenotype as our case. And as per the attached document, myeloma FISH was done, and it is negative. So So the plasma cell neoplasms may exhibit variations in morphology and immunophenotype. And as we know that The standard diagnosis for myeloma on flow cytometry is by detection of CD38 and CD138 positive cells. And mature plasma cells can express as well CD27, 81, and MOM1. And they usually lose the surface immunoglobulin, B-cell antigen, CD45, and they accumulate cytoplasmic IgM, IgG, and IgA. But the neoplastic mature plasma cells, they result from pathologic clonal expansion and secret monoclonal immunoglobulin known as M protein. Typically, they retain CD38 and 138, they underexpress CD27 and CD81, and apparently express 56 to 100, 117, 28, 20, and or 52. CD138 is a plasma cell marker that is expressed in the terminally differentiated plasma cells, but it can be lost in some of the plasma cell neoplasms. And here are some few reported cases that show loss of expression of CD138 in plasma cell myeloma. So in this case, which was published in 2019, so we have by morphology like plasma cell or plasmacytoid cells that lost CD138, but the diagnosis was made because of the morphology and CD38 expression, MOM1 expression as well. And there is another case which is kind of similar in terms of to our case in terms of CD20 expression. And in this case, they found the plasma cells are smaller than the usual plasma cells, and they more kind of resemble lymphocytes. So they have the plasmacytoid look. They are smaller in size than the usual plasma cells. They show negative 138, but strong expression of CD20, but in this case, they have cyclin D1 expression. And by flow, they have CD38 expression. And FISH analysis confirmed translocation 1114 as well in this case. So CD138 negative plasma cells, they are stem cell-like cells. They have this clonogenic and self-renewal properties, and they resemble less differentiated post-germinal center B cells. And pre-plasma cell is the term that has been proposed for this subset of cells that are CD19 negative and CD138 negative. And they say they are like intermediate between CD19 and CD19 positive, CD138 negative plasmablast, and CD19 negative, CD138 mature plasma cells within the hierarchy of plasma cell maturation. And this observation was supported by the observation that this pre-plasma cells can produce mature plasma cells in the xenograft assays. So they are, as per the morphology, they are usually smaller in size than the usual plasma cells. They resemble small lymphocyte with little or no visible Golgi apparatus, like in our case. They have a higher expression level of B-cell specific transcription factor like BCL6 and BAX5, and they may show lower expression of some plasma cell specific transcription factor like IR4. And in terms of the prognostic significance of CD138 negative plasma cell neoplasm, so it has been found that decreased expression of CD138 is associated with decreased progression-free survival and overall survival, and increased resistance to chemotherapy when it's compared to the CD138 positive counterpart. And even patients with CD138 negative myeloma who receive a high dose of chemotherapy and autologous stem cell transplant, they have a worse prognosis than those with the CD138 positive myeloma. Regarding the CD10 expression in the plasma cell myeloma, it's very rarely reported, and I found only one case report, which showed unusual CD10, CD19, 45 expression in a plasma cell myeloma, and the patient had actually immunodeficiency. And again, the presentation was presented with multiple lytic lesion raised in serum protein, IgM protein, and free light chain as well. And they have mentioned that CD10 expression can be seen in 28, can be frequently expressed in 28% of the plasma cell myeloma, and 20 can be expressed in 10 to 30%. But again, what's the clinical significance of CD10 and plasma cell myeloma? It's not yet well studied, and it's maybe an area of further research for a research. So this is about my case, and if there is any question, thank you.
Thank you, Muna. It's a very interesting and challenging case with very unusual immunophenotype, but I guess it just goes to show that neoplasm can do what they want. And just to clarify, so from what I understand, just to make sure, so it was the same in 2019. So this patient did not receive like some of the new monoclonal like antibodies or like the newer kind of clinical trials. It was sort of the regular therapies and some stem cell transplant, and that immunophenotype was kind of present already in 2019. So it's not something that changed as a result of some of the therapies. It's just it's presented that way.
Yeah, actually, about the treatment of the specific treatment that this case received, we are not really sure because the initial diagnosis was outside Canada, and he received treatment there. And even the stem cell transplant was there. But we are not sure really what we have in the know that the patient, whatever received is the myeloma regimen actually. And I'm not sure about the CD20 treatment, if he received it or not.
No, I mean, like, the anti-CD138 or there's newer drugs, like there's a whole bunch of clinical trials ongoing with specific, like that target specific antibodies. So like to your knowledge, he didn't receive any kind of.
To my knowledge, I don't know if he received it or not, but the case is now currently at UHN, and they are like reviewing the case again to start the proper treatment for it. Yeah.
Thank you.
Thank you.
I don't know if there's any additional questions from the audience. If you want to ask, you can also just unmute yourself and ask a question.
Yeah, but one thing to clarify, if that was your question, if like the patient has lost CD138 because of that treatment, actually what we received, we received the initial slides for the initial diagnosis from 2019, and still at 2019, the plasma cells are negative for CD138. They show the similar immunophenotype.
Yeah, so it seems to be how he presented.
Yeah, it seems initially.
Really interesting. Thank you for sharing the case. Very interesting.
Thanks.
Okay, thank you. So if there's no further question, we have Alexandra from the Ottawa Hospital, who also had an interesting case. Alexandra, I think I saw you earlier. You can share your screen.
Okay, so today I have an interesting case that actually leads to a lot of interesting discussions. So this is a case that someone consulted me on, a cytopathologist. They had a station 4R lymph node that they got a fine needle aspirate on. And they showed me the cytology block. And this is sort of what it looked like, essentially like a poorly differentiated neoplasm. Lots of large mononuclear cells with prominent nucleoli. And they had started with a pan-cytokeratin stain, and they did a CD45, and a CD56. And pan-cytokeratin was diffusely positive, CD45 was negative, and CD56 was positive. They also had an EMA that showed focal staining. They had BER-EP4, which also showed focal staining, and CK818 was positive. However, AE13 was negative. So they were considering a large cell neuroendocrine carcinoma. However, then they looked at the clinical history, and they saw that the patient had this history of a plasma cell neoplasm, where early in October, they had a left rib biopsy that showed CD138 positive kappa restricted plasma cells with focal cytokeratin staining. Then the T7 lesion was biopsied a few days, like 2 weeks later, and that also showed a plasma cell neoplasm that was this time negative for cytokeratin, had more typical looking plasma cells, and was also kappa restricted. Then they had a station 7 lymph node biopsy that also showed plasma cell neoplasm. This time the morphology was more plasmablastic. There was cytokeratin positivity reported. It was 138 positive, kappa positive, CD117 positive, CD56 positive, and EBV negative. A bone marrow was done. There was no evidence of plasma cell myeloma. And then this, the 4R lymph node was also targeted for biopsy, and that's what the cytopathologist received. So additional stains were added. So CD138 was positive, MUM1 was positive, lambda was negative, kappa by in situ hybridization was positive. And the previous T7 plasma biopsy was reviewed, and it did show more classic plasma cell morphology with well-delineated sort of normal looking plasma cells that were negative for CK7, negative for pan-cytokeratin, but in this case, the decal had been done, but it was negative for pan-cytokeratin, and kappa light chains were positive by in situ hybridization. And then the rib lesion looked like this, and it had only focal pan-cytokeratin staining. So what's the final diagnosis? And I should have done a question for this for the group, but essentially the diagnosis came down to plasmablastic myeloma versus a plasmablastic lymphoma. And this was a very challenging case, given that the marrow was not involved, because you have this large lesion centered around T7, this paravertebral mass, and then you have these thoracic lymph nodes involved by this neoplasm. But given that it was CD117 positive, EBV negative, no history of HIV, there was presence of more typical plasma cells in that first biopsy. The patient is being treated as a plasmablastic myeloma, acknowledging that it is a very challenging case. And so just as a quick review, not the main point of the presentation, because the main point of the presentation is to talk about cytokeratin positivity in hematolymphoid neoplasms, because the cytopathologist that brought me that case was shocked by the pan-cytokeratin being diffusely positive, and they had never heard of it, or had never considered a hematolymphoid neoplasm until they saw the clinical history. So I thought it was a good case to show, to remind people that that can happen. But because we're hematopathologists, we can also talk about how you can tell a plasmablastic myeloma from a plasmablastic lymphoma, because it's always good to review that. But EBV positivity would favor plasmablastic lymphoma. Plasmablastic myeloma usually has crab features. Plasmablastic lymphoma usually is an extranodal mass showing up in oral cavity, GI tract, or lymph nodes, frequently in HIV positive patients. There are genetic features you can look for, which in our case were not looked for, but we'll probably recommend that. And then ancillary studies can help, and as well as, anyways, integrating the clinical presentation and all the findings. So here's another case, example of a plasmablastic neoplasm that this one came with a lymph node biopsy. And the H&E on the neck lymph node looked like this. And this went to head and neck pathologist initially, and they did a pancytokeratin, and it was diffusely positive. However, luckily, this case also had a concurrent flow cytometry that showed us plasma cell neoplasm. So despite the fact that this case was CD45 negative and pancytokeratin positive, the hematopathologist alerted the ENT pathologist that flow showed a plasma cell neoplasm, and the case got past the heme path, and indeed it was confirmed that this was Memon positive, kappa light chain restricted by in situ hybridization, and lambda in situ hybridization negative. And so in terms of clues, because people ask me, well, anyone I've told about these cases usually gets scared about the concept that you can have pancytokeratin positivity in a hematolymphoid neoplasm. And what are clues? So obviously clinical history. Seeing lots of apoptosis for me is often a clue that I'm dealing with something more likely to be hematolymphoid than a poorly differentiated carcinoma. And then just being aware and doing stains. So anyways, back to the second case. The second case also had no marrow plasma cells. It only had lymph node-based disease. The patient was EBV negative, and in that case, c-MYC translocation was present, and so that case is being treated as a plasmablastic lymphoma. But as you can see, the cases can be very challenging. So this is my first quiz question. So we'll share the results. So yes, most people got it right. It is all of the above, though ALCL is definitely the most frequently, I think, actually positive one there. Though surprisingly, mantle cell lymphoma has been reported to be pancytokeratin positive in up to 26% in some series, depending on the antibody they're using. But so these are hematolymphoid tumors that can show cytokeratin positivity. So ALCL, mantle cell lymphoma, plasmablastic lymphoma. So here, series report 15% of cases can be positive. Up to 30% of cases of anaplastic large cell lymphoma can be positive, mantle cell lymphoma, but that one usually looks hematolymphoid, so not as big of a mimicker. It's the plasmablastic myelomas and lymphomas that are more tricky, and anaplastic large cell can definitely look more epithelioid and could easily be called a poorly differentiated carcinoma. Apparently, CLL, SLL can also show cytokeratin positivity, rarely diffuse large B, and peripheral T-cell lymphoma, also case reports exist. Typically, staining can be focal and granular rather than diffuse, but as we saw with the two cases I showed, in those cases, the pancytokeratin was diffusely staining, and it was 818 that was also diffusely staining. So next poll, I actually didn't know this one. And just a caveat, these answers are based on open evidence AI model. It's a AI model for medical knowledge, or it's meant for doctors. You need a MINC number, a medical identifying number, to get access to it, but I find it's reasonably decent for answering like questions like what proportion of tumors are X positive or negative, as it draws from the literature, and it will provide you the references. So it's good for finding like case series and things like that. Anyways, so the poll showed, yeah, people were again correct. Myeloid sarcoma is actually the least frequently positive, negative for CD45, anywhere from 0 to 9%. I did actually have a myeloid sarcoma that was negative for 45, so I have seen one, but usually they do at least show dim 45. So classic Hodgkin lymphoma, as we all know, is usually 45 negative. Blastic plasmacytoid dendritic cell neoplasm, also nearly CD45 negative. Follicular dendritic cell sarcoma, kind of controversial, not really considered hematolymphoid, but it's in our WHO textbook for the hematolymphoid classifications. So it's kind of good to know that it's 45 negative. So it's like another thing you could have on your differential. If you're faced with carcinoma or like some kind of neoplasm that's not staining with anything. Plasma cell myeloma, very, very commonly 45 negative. Plasmablastic lymphoma, also commonly 45 negative. Anaplastic large cell lymphoma, 40% CD45 negative. And then BALL, especially in children, can be CD45 negative. And that can, though usually the morphology isn't that, like it's going to look more typical, not so epithelioid, and myeloid sarcoma. And then there are, of course, case reports of various other lymphomas being 45 negative, but these are extremely rare. So like I have personally seen a diffuse large B cell lymphoma be 45 negative. And I've seen high-grade B-cell lymphoma that for sure, that recently, actually, I had a case that was 45 negative, but they're rare. So when reviewing this topic, so people often come to my office when they have something that doesn't stain with anything, like a poorly differentiated neoplasm, and it's negative for pancytokeratin, it's negative for SOX10, S100, negative for CD45. They come to my office and they're like, Alex, how else can I exclude a poorly differentiated hematolymphoid neoplasm? And depending on the amount of tissue, you might not be able to do like a super extensive panel. So sort of, and this is sort of open to the group. I don't know if other people have better suggestions, because I sort of just came up, these are the ones I use. So CD30 for sure. Anything that's not staining with anything should get a CD30. Anaplastic large cell lymphoma can be a real mimicker. It can have a spindle cell morphology. It can look like Hodgkin. It can look like, it can be in a histiocyte-rich background. It can have a small cell variant that looks more like diffuse large B. And then it can also look really large and anaplastic. So CD30 is like, for sure, if you have something not staining with anything, you need to do a CD30. I like CD79 and MUM1 for plasma cells and B cell neoplasms. CD79 is kind of like a 2-for-1. It should hit plasmacytic things, and it should hit B cell things, rather than 20 just hits B cell neoplasms. MUM1 it will hit plasma cell neoplasms most of the time, but it also hits melanoma and other poorly differentiated malignancies, so it's not specific. CD43, I like it as a secondary second stain to CD45. It's a pan T myeloid marker. It will stain histiocytic things. And it usually is positive. It will stain anaplastic large cell lymphoma, not always, but your 30 sort of covers you for that. But my 43 is kind of more my myeloid sarcoma insurance. Because MPO doesn't have to be positive, but that's another one you could think of. And then kappa and lambda, if you're really concerned that it could be something plasmacytic, plasmablastic, then kappa lambda, especially the in situ hybridization stains, are the most specific. Like if your MUM1 comes back positive, then for sure you would add on a kappa and a lambda in situ hybridization. Yes, there are very, very, very rare cases of like light chain negative plasma cell neoplasms, but we won't worry about that. But if you want to prove something's plasmacytic, you and especially since poorly differentiated plasmacytic, like plasma myelomas, can lose 138. So, and 138 can stain epithelial things. So you do not want to be relying on CD138 to call something a plasma cell neoplasm. You really want to have that light chain when you don't have good morphology. And so these are just examples of plasma cell myelomas that I've had that have been like really anaplastic morphology where you wouldn't have thought of plasma cell myeloma, and only it was the clinical history that sort of led to that diagnosis. But here's another example of a really anaplastic myeloma that on first glance, that's the last thing you're thinking of. And so it's just good to be aware that these things exist. And then this too was a myeloid sarcoma with erythroid differentiation that was totally 45 negative. And I caught it with the CD43 was positive. So I took over the case and it ended up being a myeloid sarcoma with erythroid differentiation. And it didn't have the typical blast morphology that I think of with myeloid sarcoma. So I also thought this case was neat because it looked really, sort of more like it could be a poorly differentiated carcinoma. So yeah, so anyways, that's all I have. So I hope that was helpful.
Yeah, I think at least in the chat, people were engaged in just sort of sharing the unusual keratin positive or not staining with anything type of issues that you describe, where they kind of there's a question around like what could this be, and just yeah, I think this is very very relevant topic. Let me just, it was mostly just sort of comments. Someone mentioned like acute myeloid leukemia that was pankeratin positive, gastric myeloid sarcoma with a pan-CK dot-like positive.
Yeah.
Oh, someone was asking, Luke was asking if your kappa lambda hybridization worked for B cells.
No, it doesn't. It only works for plasma cells. Rarely it will stain a B-cell lymphoma, but mostly no. There's not enough light chains there. Or mRNA light chain.
A lot of people just saying that it was very helpful, very nice presentation, so I think it's a very relevant topic that we all commonly encounter in our practice.
Yeah, did anyone have any additions to like how they usually screen, like if they have something that's not staining with anything, how do you completely exclude hematolymphoid? Because like especially myeloid sarcoma, like there's so many things it can stain or not stain with that, like if you're dealing with limited tissue, Yeah, it's hard. You can't be completely exhaustive, in
No.
most cases.
I think your CD43 is a good idea. Like the CD30, I think, like you said, it's kind of like a core thing for anything that's sort of not staining with much, or a bit of whooshy staining with keratin, sometimes even more. But yeah, I think the ones you mentioned are. I don't know if anyone else has questions or comments. Okay, well, I think this is all we had for today. So unless there's additional comments or sort of Luke was saying that you can add the CD34 and a monocyte stain if possible. Again, depending on the amount of tissue that you have and I suppose like morphology.
Yeah.
Yeah. 34 is good. In a way, it can be tricky though, because I've noticed sometimes people tend to associate 34 with acute leukemia, and but not all.
It can be positive
Obviously,
and just.
yes, yeah, and like
Not
obviously not all leukemias are 34 positive, so there's kind of like both sides to the coin. Yeah, seems so. Yeah, so then I think we can give everybody back half an hour of their time. But thank you everyone for joining us, and thank you for bringing the excellent cases and preparing a very engaging presentation. Like it was a great review of like it's good to just have like a sense of those percentages and how often these things can happen. We all kind of know, but getting a sense of frequency and sort of like most common entities that can do that is very useful.